Hello, friends and colleagues. Today we are going to talk about how to do a complete and thorough neurologic exam. For those of you who don't know me, my name is Sarah Roos. I have to disclose that I do work for Boehringer Ingelheim. I'm a technical manager for them, but none of this is remotely product associated. This is just going to be, again, how to do a complete neuro exam. So I think when we start off with the neuro exam, step one really is just to identify abnormalities. I think sometimes we kind of try and jump too far ahead from the get-go, and especially when you're starting off, kind of just start off saying, is this normal or abnormal? Don't overly try and interpret it at first until you complete your entire exam to determine what is normal versus abnormal. Then once we have that list of abnormalities, then we can look at it and say, okay, are these associated with the neurologic system? And if so, can we localize them? And I think this is the part that always wants to give everyone a seizure, is this term of neuroanatomical localization. But really don't let it scare you too much. We're going to try and simplify it here. But I think your big questions really are, can I account for all of the abnormalities that I see in this horse with one lesion or more than one lesion? Even if you can just answer that, even without specifically localizing to a portion of the spinal cord, but you can say that there's forebrain and spinal cord, that still is going to help you a ton in terms of starting to order your list of differentials. So really, again, if you can simplify to one lesion or more than one lesion, great. Obviously, in many situations, we'd like to be more specific than that. And again, I'll kind of talk you through some of that, but that should be your first question. Because again, that's going to help you a lot to form your list of diagnoses or of differential diagnoses. Again, when we start getting into things like multifocal disease, that drastically raises our likelihood of things like EPM versus if we have just one abnormality or just one localized lesion. Based upon what we come up with for that list of differential diagnoses, obviously that then determines what sort of diagnostic testing we're going to recommend to that horse owner and potentially treatment and prognosis. So just like any portion, honestly, of veterinary medicine, we're going to start with a good history. And signalment's going to be important. So again, your list of differentials is going to be a little bit different if we're talking about a rapidly growing 2-year-old thoroughbred colt versus a 15-year-old quarter horse pasture pet. So signalment is certainly going to be important. Vaccine history is going to be really important here and important to be specific. I think it's really easy to just ask an owner, is your horse up to date? They say yes, and we move on. What does up to date actually mean? So we really need to get specific in terms of exactly what they were diagnosed against and when, especially if it's a younger horse. Did they receive an appropriate initial booster series? So did they get that priming series of 3 vaccines? Or have they only ever been vaccinated once in their life, especially when we talk about the mosquito-borne illnesses, so things like Triple E and West Nile, really important that they had that appropriate initial booster series. We also want to know, like I said, specifically what antigens were they vaccinated with and who gave them. Were those administered by a veterinarian? Did you administer them and you have good records of it? Or were they administered by an owner? Obviously, if they were owner administered, there's always a little bit more question about appropriate administration, as well as honestly just appropriate storage and maintenance of vaccines. So really try and boil down to exactly who got what and when, especially if those potential mosquito-borne encephalitis are on your list. Herd status is going to be important. Is only one animal affected or are multiple animals on the premises affected? Obviously, again, that's going to drastically change your potential list. If you have multiple animals affected, then you're going to worry about more toxin type related things like botulism or whatnot. Obviously anymore, minus maybe currently during this corona outbreak, horses travel a lot. So even if you're practicing in the north somewhere where maybe you don't see a ton of mosquito-borne illness in March, if that horse just came back from Florida, we certainly still have to have that on the list. So any recent travel in that horse, where were they? What time of year were they there? When we start talking about some of those infectious organisms. Diet's going to be important, both what the horse routinely eats, but then any new changes in feed suppliers. So did they just get a new bale of hay or a new bag of feed? That again could potentially include some of the toxin things. So things like botulism, monensin, blister beetles, all of those feed related abnormalities that we might see. Like I said, also their long-term diet. So if we're thinking about things like equine degenerative myelopathy, and potential associations with vitamin E, has this horse never seen green grass in its life? All of those things can become important. And then any medication, so anything maybe that you prescribed or anything that the owner's just been giving without your knowledge, or again, has maybe gotten a new supplement or a new medication that they got somewhere else that, has come from an unregulated source. So important to, again, without kind of pointing fingers at them, because you really need the honest information, really try and make them be forthcoming with medications as well as supplements that that animal may be receiving. And then when we start to boil down to that individual animal, duration and progression of clinical signs. So was the horse truly totally normal yesterday? Maybe jumped a course and seemed fine and is markedly abnormal today? Or is this something that maybe they've been noticing a slow progression over weeks or months? Also, have they tried any treatments? So we ask about, new medications that animal has gotten, but also, have they tried anything subsequent to the first time that they recognize clinical signs in this horse? So if it's a gait abnormality, let's say, have they tried giving the horse a non-steroidal? Have they tried a butyl and the gait abnormality has not changed at all? All of those bits of information can be quite helpful. And then we're going to actually start our physical exam. And so we always want to start with vital parameters. And fever is going to be a huge one. And so this is going to be one that even when you talk to that horse owner on the phone, trying to ascertain whether that horse has ever had a fever. Even in some of these very acute neurologic cases, the owner may give buterbanamine before you can get there and mask a fever by the time you actually examine the horse. So certainly encouraging that horse owner to get a temperature on the horse prior to administration of any sort of non-steroidals will help you to decide, did this horse ever have a fever? And obviously when we start talking about neurologic disease in the horse and fevers, obviously West Nile and Triple E certainly can have fevers, and that's important to note, but probably most importantly is if we're concerned about things like equine herpes, that presence of a fever and neurologic signs may drastically change what you do from a personal protection standpoint, as well as biosecurity, calling in state vets, all of those sorts of things. So vital parameter is really important. Also really important to look at the horse's eye. The eye is the window to the soul. So looking at, the eye from both the outside as well as looking at the back of the eye. So here's a fundic exam on the horse. We can see the tapetal and non-tapetal junction here with the optic disc. And when we see this moth-eaten or kind of bullet hole appearance around the optic disc, that is going to make us highly suggestive of or highly suspicious of equine motor neuron disease. So especially if that horse from the outside, is the horse standing on an elephant ball, maybe preferring to lay down more, and you look at the back of the eye and see these sorts of lesions, you pretty much have a diagnosis of EMND. If just even looking at the horse's eye from the outside, we see this prolapsed third eyelid, obviously tetanus is going to jump to the top of the list. So obviously we're going to talk about some very specific ocular type reflexes as we go through our cranial nerve exam, but even just looking at the eye and the surrounding tissues as part of your physical exam is important. And then again, we'll talk a little bit about this as we go through the rest of our exam, but really, looking at the entire horse for any sort of muscle symmetry or more importantly, muscle asymmetry. So, looking at the horse's back muscles, gluteal muscles, all of those things can be important. Palpating for and looking for any joint swelling. So especially again, if that horse has a gait abnormality, if you feel a big swollen hock, that's obviously going to change you probably from a neurologic exam to potentially more of a musculoskeletal exam. So really feeling for any sort of joint swelling, both palpating for neck pain, so kind of squeezing on the horse's neck, as well as asking them to do some neck flexions can be helpful to look for neck pain, as well as sweating patterns. So are there areas that horse is abnormally sweating? So maybe some, again, difference right versus left or very focal areas of swelling. So we're going to look at this horse. So this was I think he's about a 16-month-old Missouri Foxtrotter, I believe he was. He was a Foxtrotter or Tennessee Walker. But again, a kind of youngish horse at 16 months. You can see even just looking at him from the outside that he does have muscle atrophy here along his neck. And it's a little bit hard to see, but he actually also had a pretty focal area of sweating here. And then we're going to watch him do some neck flexions or lack thereof. So you'll see trying to move to the left here. And again, you may just be able to discern a little bit of that sweating there on the left side of his neck. But normal horse, especially young horse, really should easily be able to get behind his elbow to get to the hay that he very clearly wants to get to. But you can see he can only make it so far on the left. Sorry for the bad iPhone video. And then here going to the right, this was as far as he could go. So he really could not flex his neck to the right really at all without meeting significant pain. You can see how much he wants the hay and just can't do it. And ultimately, this little guy actually had discal spondylitis. So not a super common diagnosis in horses, but certainly something that we can see. And so you can just make out here collapse of the disc space and remodeling of the caudal aspect of C5 here. And again, for those of you who maybe don't look at a lot of neck films, we'll diverge for 1 second. How I know this is C5 is by looking at this particular vertebrae, which you can generally pick out C6 because it has these sled runners. So it has these more pronounced ventral projections. So you can orientate yourself there. So we know that says C5, C6, C7. And again, the caudal end plate here, you can discern hopefully is a little bit different here on C5 than it is on C6. So those are all going to be portions of kind of our basic physical exam, and then we're going to start moving into some slightly more specifics of the neurologic exam in terms of behavior and mentation. And a lot of times these are things that you may be observing even as you're getting that history and kind of starting your physical exam of the horse, that often you're almost subliminally recognizing, how the horse is responding to you and to its surroundings. And this obviously is going to vary a little bit depending upon, did you go to the farm to see the horse and he's in his normal environment, or did the horse haul into you and is maybe in a markedly abnormal environment for him, is a little bit going to alter, how excited you might expect any individual horse to be or kind of how reactive to their surroundings they are. So you always have to take that a little bit with a grain of salt. And this is where sometimes, really trusting the owner's interpretation of what is normal or abnormal for their horse can actually be quite helpful. I know sometimes we're skeptical sometimes of what owners might say to us, but owners do know their horse as well. And so if they, can tell you that this is a marked behavior change for an individual horse, we do sometimes have to believe them on that. And I think this is where sometimes there is a little bit of confusion or misinterpretation, I'd say, between behavior and mentation. So they are two different things, and they come from different areas of the neurologic system. So when we start trying to get into that neuroanatomical localization, it can be important to try and differentiate these two. So behavior is going to be controlled by the forebrain. And so things that we're going to look for in terms of behavior are going to be that horse that is overly docile, overly aggressive, or potentially manic. And the one example I always use of this was I had a horse that she was a 5-year-old chestnut warm blood mare who came in and was legitimately trying to kill people as we were trying to get blood from her. And I'll be 100% honest, I kind of just wrote it off as she was a redheaded mare. But the owner was like, no, this is very abnormal for her. She's usually a very sweet mare. I don't know why she's being so aggressive. Long story short, the owner was right and I was wrong. She actually was a lovely redheaded mare that when her neurologic disease subsided, she was not, in fact, an aggressive horse. And so again, kind of trusting the owner's change in behavior would have helped me in that particular case. Other things that we will see related to forebrain and behavior type changes will be that horse that is compulsively circling, head pressing, or seizing. And then a head and neck turn. So we're going to talk a little bit when we get into cranial nerves, we'll talk a lot about head tilts. But if you have a horse that has an entire head and neck turn, so you can see that this mare really has more even of a turn than she does a tilt, where her entire head and neck are still perpendicular to the ground, but are deviated here to the right. That is going to go along with forebrain disease, versus this particular horse just has a significant head tilt where his entire poll is dropped to the side. I'll be honest, this horse was not neurologic. You can make out my hand here. This was the first time this horse had ever been braided and I was scratching for him. But important to differentiate again, if they have a head and neck turn, then that is going to go along with forebrain disease. Again, we'll talk about tilts and how tilts can be relative to cranial nerve disease in a second. So like I said, we need to separate behavior and mentation. So mentation is going to be that response to stimuli. So it's either going to be that horse that's overly responsive, that hyperesthetic horse that you touch them, and they act like they were stung by a wasp, and have a come apart with just a routine level of contact. Appropriate would be alert, so they're alert to their surroundings. then moving into being lethargic, obtunded, or comatose if they're not responding appropriately to their surroundings. So that's going to be mentation, and that actually comes from the reticular activating system, which is getting into the brainstem. So again, if we can really try and discern behavior changes versus mentation changes, then we can start to localize, is this forebrain disease, or are we starting to move into brainstem disease? And then as we talk about brainstem, obviously we start talking more and more about cranial nerves. You can use whatever mnemonic you like or have been taught to try and remember the order of the cranial nerves. I will not be recording mine for posterity. But we're going to go through them in numerical order. I'll be honest, when I do my cranial nerve exam, I kind of do them more kind of in anatomical location on the horse's face, but I think for teaching purposes, it's easier, kind of more systematic to go through them, one by one. I think just like any portion of any sort of exam that you do in an animal, come up with a scheme or a system that you do the same way every single time that you do it until it becomes second nature, and then you won't leave things out. And so again, maybe you choose to stick to that, the number aspect of it, or again, you just figure out some system that works for you, but just make sure that you're always doing it the same. The other thing really when we talk about neuro exams is make sure that as much as possible, you're also trying to do it the same right to left. Obviously for all of these things, we're going to be looking a lot for symmetry. And so you want to make sure that either you're standing directly in front of, or when we get to some of the moving stuff behind the horse, or that you're standing right versus left as you're doing right versus left side of the horse, so that everything is really as systematic and as controlled to look for those asymmetries as possible. So cranial nerves. So we're going to start with cranial nerve 1, which is olfactory. It's one that honestly we aren't really aware of any diseases that preferentially pick off olfaction in the horse, nor do we really have a good way of actually testing olfaction. In general, I say if they have an appropriate appetite, they probably can smell okay. Trying to do things like, wafting an alcohol-soaked cotton ball in front of them is not effective in terms of testing olfaction. That's actually more testing trigeminal. So really, olfaction, we kind of ignore. Moving into cranial nerve 2, now this is the optic nerve. We have multiple different ways that we can look at the optic nerve. So we can look for vision by doing several things. So we can look for menace, and so again, kind of poking our finger towards the horse's eye, which I'll show you a video of in a second, to see if they blink. We can look for pupillary light responses and dazzle responses. So again, that's going to be using a bright light to shine in their eye to look for that pupil constriction. And if the light is bright enough with that dazzle, they should actually blink or move away. And you will certainly come to realize, especially if you're doing any sort of ambulatory practice, sometimes it can be really hard to find an area dark enough to actually do good PLRs and dazzles. So do the best that you can. Certainly if you're in a barn somewhere and you can turn off overhead lights, or move the horse into maybe a wash stall or something like that you have a little bit more control over the ambient light. That's going to be helpful to really try and look for PLRs and dazzles. In terms of pupillary light responses, I'll be 100% honest, I mostly focus on the direct PLRs. If your direct PLR is normal on both sides, honestly, you really don't gain a whole heck of a lot from trying to do indirect or consensual PLRs. So really focus on having that good light to do your PLRs and dazzles. And then you can also do an obstacle course. So especially if part of the complaint is, that the suggestion is that maybe the horse is not seeing as well out of one eye versus the other, is that you can blindfold each eye independent of each other. And then the obstacle course can be very simple. It does not need to be like a border collie agility course. So just having a trash can in the middle of the barn aisle, again, cover one eye, loosely lead the horse towards the trash can on a loose lead line. Obviously, a normal horse will avoid bumping into it. If they run into it with one eye versus the other blindfolded, then you can discern or appreciate that likely the unblindfolded eye does not have appropriate vision. So when I do menaces, I do often, and I don't believe I do it in this video, but often I will do a quick palpebral first. So I'll just kind of touch the surrounding eyelid for a couple of reasons. One, to make sure that the horse can blink, because obviously if they can't blink, when I go to menace them, they're still not going to be able to blink. They would, if they could see my fingers coming, they would still move their entire head away. But I do like to know, okay, can this horse blink or not before I start menacing them? So I'll often do kind of a quick palpebral. The other reason to do that is it kind of makes the horse realize that you mean business. Especially a lot of horses that are been used to being handled for many years don't actually think you're going to poke them in the eye. They trust you maybe more than they should. So again, by not poking them in the eye, but poking them in the surrounding eyelid tissue, just makes them realize, okay, when I am moving my hand towards your eye, I might actually hit you. So you should, blink or move away if you can see me. And then, like I said earlier, you want to do each side the same. When I'm doing menace, I also make an effort to not hit the eyelashes, especially if they're really long, and also not move a ton of air towards the eye, to where it's more that the cornea is feeling the wind resistance more than that the horse is seeing me. And then you also want to come from both the nasal aspect, so kind of more rostrally, as well as temporally, because if you think back to the optic chiasm and what crosses over versus not, there is a portion of vision, probably about 15%, that does not actually cross that optic chiasm. So we'll watch this video. So you can see here on the left, I'm coming nasal, temporal. You can see she does not blink at all. Moving over to the right side, nasal. Do that again, nasal and temporal. You can see that she blinks appropriately on the right, come back to the left, and this mare did not have any vision on the left side. So moving into cranial nerve 3 is going to be the oculomotor nerve, and it does a couple of things. So I think most commonly we think of it in terms of extraocular positioning or eye positioning. We're going to go through 3 different cranial nerves that all play a role in eye position. And again, for purposes of vet school, you probably do need to actually know exactly which muscles all of them innervate and be able to discern which is which. I'll be honest, from a practical standpoint, if you can just recognize that it is abnormal, that probably is going to localize you just about well enough. But if we think about cranial nerve 3, it controls the majority of our extraocular muscles. And if a horse has a lesion in the oculomotor nerve, or area that if the area of the brainstem and or the peripheral oculomotor nerve is damaged, then we're going to have ventrolateral strabismus. The other thing that the oculomotor nerve does, though, is that it also plays a role in pupil diameter. So when we are looking at our PLRs, we are also looking at both optics, so both cranial nerve 2 as well as cranial nerve 3, the oculomotor nerve. So you want to look for pupil size and symmetry as well as PLRs. And I'll be honest, we don't see a lot of diseases that preferentially just pick off cranial nerve 3. This is the only horse in my career I've ever seen that only had a cranial nerve 3 abnormality. And so if we look at him here, we can see that his right eye is normal. So it is maintaining, appropriate horizontal plane to the ground, and has a normal pupillary size, versus his left eye, you can see is deviated laterally, and you may be able to discern that this pupil is also much more markedly enlarged than his right eye. And he had a lesion that had just picked off that peripheral left oculomotor nerve. So this is one spot I go maybe slightly out of order. So when I think about eye position, obviously we think about 3, and then the other 2 cranial nerves that we think of for eye position are going to be 4 and 6. So we're going to talk about 3, 4, and 6 all together. So we already said 3 does eye position as well as pupillary size. Cranial nerve 4 is the trochlear nerve. It does just the dorsal oblique extraocular muscle. So if a horse has an abnormality in the trochlear nerve, they will have dorsomedial strabismus. And then the third, or the other, I should say, cranial nerve that controls eye position is going to be 6. So we've got 3, 4, and 6. So 6 is abducens. It is going to control the lateral rectus. So a lesion in the abducens nerve would result in medial strabismus. The other thing that 6 innervates is the retractor bulbi. So again, we're not going to touch the horse's cornea, but if you just kind of smooge their eyelid over their eye and then press on their eye, they should retract their eye into their head. and that is controlled by 6. So that globe retraction. So if they cannot do that, either they have a mass behind their eye or they have cranial nerve 6 abnormalities. So both 3 and 6 innervate some other things. So again, 3 does pupil size as well as eye position. 6 does eye position as well as retractor bulbi. 4 only does eye position. So backing up for 1 second is going to be cranial nerve 5. So cranial nerve 5 is going to be the trigeminal nerve. And it has 2 different functions or 2 different roles. So it has both a sensory as well as a motor component. So it is going to provide sensation to the face and really to the bulk of the face. So it is going to be important when we talk about the palpebral reflex, nasal septum sensation, as well as ultimately the corneal reflex. So again, when you're doing menace, if you move a ton of air towards the horse's eye, you may actually be stimulating trigeminal nerve. To me, honestly, from a sensation standpoint, the one that is most consistent and easiest to really look for is going to be that nasal septum sensation. So essentially just sliding your thumb up their nose, almost like you're going to pass a nasogastric tube, and touching that nasal septum. Even the most well-behaved, stoic, lovely, well-handled horse in the world should respond when your thumb touches their nasal septum. And really, they should continue to respond and try and get away from you. They really should not enjoy that sensation. So that's going to be one that I think is very consistent. And if the horse doesn't respond to you touching their nasal septum, either they have trigeminal dysfunction or they're so markedly obtunded that they're not responding to anything, and usually you've already figured that out at this point of your exam. And then there is also a motor component to the trigeminal nerve. And so it's going to be motor to the muscles of mastication. And I think this is when people mostly think of the masseter muscles. And so you can see this quarter horse gelding. It's always a little bit hard, I think, to tell just in the still picture, but hopefully you can appreciate that his entire right masseter is essentially gone. Again, this is a quarter horse gelding, so should have a decent amount of jowl to him. And if you could see his left side was still normal. But it's important to recognize masseter, but also to think about temporalis and pterygoid. And so a lot of times I'll kind of tuck their forelock, behind their halter, behind an ear, so that I can really look at both their temporalis, and then their pterygoid is what runs under the supraorbital fossa here. You can see this horse did actually have some atrophy of all of that area as well. If it's been going on for long enough, so a couple of weeks or is severe enough, you certainly can appreciate, just looking this muscle atrophy. Sometimes it's a bit easier to feel, so I try and stand directly in front of the horse and feel both sides of it, because sometimes even if my eye can't pick it up, my fingers might be able to feel a subtle difference between the two. But then the other thing that really is helpful is to also pick up their lips and look at their jaw. So again, if they maybe didn't necessarily have enough masseter atrophy that you could, feel it and appreciate it visually, but had already started to develop loss of tone to one side or the other, they're going to start to have jaw deviation. So you can see this particular horse, the jaw is deviated here to the right. So the lower jaw is deviated to the right because this horse did actually ultimately go on to develop left masseter atrophy. So it had lost tone in the left and was being pulled to the right. If a horse happened to have symmetrical trigeminal disease, so actually had lack of innervation or strength to both sides of the masseter, then he actually would not be able to close the jaw at all. So these teeth would not be opposed. So again, can be a helpful thing to look at the jaw alignment or apposition as well when looking for some of the more subtle or earlier trigeminal lesions. So we already talked about 6, so we're going to jump ahead to 7. So cranial nerve 7 is going to be the facial nerve. And so it is motor to the muscles of facial expression. So it is going to be a lot of your palpebral reflex. So again, the ability for that horse to blink. So to feel it is going to be cranial nerve 5, but then to actually blink it is going to be cranial nerve 7. But then we're also going to look at, can the horse move its ear, its eyelid, and its muzzle. This particular mare you can see has right ear droop. It's a little bit hard to pick out, but she did have some right-sided ptosis, and then obviously she has some right muzzle deviation or nasal deviation as well. So she had a lesion of cranial nerve 7 on the right-hand side. The thing that can be nice about cranial nerve 7 is with this mare having ear, eye, and nose, we know that her abnormality is somewhere, brainstem, between the brainstem and the ear. If her ear were normal, but her eye and her muzzle were both abnormal, then you could say, okay, it's a more peripheral lesion. So the brainstem is fine, but the lesion is actually somewhere more in the auriculopalpebral range. And then obviously if she had normal ear and eye, but just had muzzle deviation, then we could be saying that it's a much more peripheral lesion, actually down here in the nasal area. Sometimes ptosis is really obvious, sometimes it's a little bit more subtle. And so one of the things that I do like to do is to really kind of stare at their eyes, and their eyelashes should come out of their eyelids at about a 90-degree angle. So you may have one that is still able to blink and to cover their eye, but the eyelashes are a little bit deviated ventrally. That's going to help you to pick out some of the more subtle facial lesions. So obviously, again, this mare was right, this mare was left. So again, you can see a little bit of droopiness to her left ear. Again, hopefully, against this dark background, you can discern that she does have some deviation of these lashes, and then she also has that nasal deviation. The other thing that's important to remember about facial nerve is that the innervation to the nasolacrimal duct, the parasympathetic innervation to the nasolacrimal duct, runs along with cranial nerve 7. So often if you have a cranial nerve 7 deficit, that horse may also have lost the innervation to that lacrimal gland and will have dry eye. So if you have a Schirmer tear test, great, go ahead and do it. If you don't have one handy, just take that into account, because obviously if this horse can't blink and has decreased tear production, that makes them incredibly high risk for significant corneal ulceration, because they're also not making tear film, let alone being able to disperse it over their eye. So you're going to want to be really aggressive with both staining the eye to make sure that there's not already a corneal defect, and if there is, you're going to have to treat it quite aggressively. So moving into cranial nerve 8, we now have vestibulocochlear. So there's both a hearing as well as a balance portion of this. So we'll talk about the posture and balance bit first. So a horse with cranial nerve 8 abnormalities will often have a head tilt. They may actually be leaning against a wall, falling, and or circling. Again, if it's going to be a peripheral lesion, all of those things will be towards the affected side. When we talk about head tilts, we want to talk about which direction the pole is going. So this mare had a head tilt to the right because her pole is going to the right. Obviously, it's important just to clarify that because their nose goes the other way. So we want to describe a head tilt in terms of which direction the pole is going towards. You may also a little bit be able to tell, it's kind of hard to tell in a still picture, but all of her body weight was also leaning to the right side. So she was not one that was holding herself against a wall, but was leaning her entire body to the right. You can also maybe discern that she also had right ear and nasal deviation. You'll probably notice from both the last set of pictures as well as this picture, we often do see cranial nerve 7 and 8 deficits together, specifically with a disease that's called temporohyoid osteoarthropathy, or THO. We won't get into too much on that disease, but if you see a horse that has cranial nerve 7 and 8 deficits, that particular disease should jump to the top of your list, and certainly encourage you to go read more about it if it's not a disease you're familiar with. So this, like I said, we look at head tilt. We're also going to look at eye position. So again, a normal horse, if you take their chin or their halter and pick their head up, they should roll their eyes ventrally a little bit to maintain that horizontal plane with the ground. If they don't do that, that is going to be abnormal. Normal horses should also have what we call physiologic nystagmus. So I always think of this as kind of the figure skater response. So a normal animal, if we take their head and move it in a direction, they should get fast phase in the direction that we're moving their head with slow phase recovery to the other side. So as I move this mare, as I move a horse's head to the right, they should get fast phase to the right. As I move their head to the left, they should get fast phase to the left. And that's normal. And like I said, I think of that as kind of the figure skater response. So that's how when figure skaters do their little spins and whatnot, how they don't lose their balance, so that they're kind of compensating as they go. If a horse does not move their eye that way when you move their head, that is abnormal. So they should do that in both eyes when we move their heads in subsequent directions. Horses should not have resting or positional nystagmus though. So resting would be just that at rest, you not manipulating their head in any way, shape, or form. If their eyes are flicking one direction or the other, that is abnormal. Or if we just take their head and just pick their head up. So again, I'm not moving it side to side, but I'm just picking their head up a little bit, if that induces them to develop positional nystagmus, that would also be abnormal. So physically moving their heads to induce physiologic nystagmus is normal, but if they have nystagmus or that eye flick at any other period of time, that is going to be considered abnormal. The other portion of the vestibulocochlear nerve is going to be hearing, so that's going to be response to noise. So sometimes we can say, if we clap or we wrinkle a peppermint wrapper or something like that, if they can hear it, then they're probably normal. If we really want to discern, especially one side versus the other, we're going to have to do a brainstem auditory evoked response. So in terms of nystagmus, I do have a couple of videos here. We'll look at this little pony first. And so you can just make out a little bit, it's not a great video, I apologize, fast phase to the right with slow phase recovery to the left. What is really handy is when they also have a corneal ulcer that takes up stain, because it makes it really hard, or really easy, I should say, to see their eye move. So in this one, you might be able to appreciate the nystagmus a little bit better. And so this course actually had, for the most part, fast phase to the left and slow to the right, but you could notice it was not even always directly horizontal. Sometimes it's actually almost rotary, but for the most part is a fast phase horizontal to the left. And so again, sometimes you really do need to take some time, stand on each side of the horse and look at each eye independently of each other to really look for that nystagmus. The other thing that is nice is most horses will also kind of blink in synchrony with their nystagmus, so you can also look for that, especially if you are somewhere that the ambient light makes it really hard to kind of see exactly what their pupil is doing. So that was cranial nerve 8. So moving into cranial nerve 9 is going to be the glossopharyngeal nerve. And so glossopharyngeal is going to be sensory and motor to the pharynx. So it is going to be involved with swallow. So if any portion of the horse's history has included, choking, dysphagia, anything like that, then I'm going to, potentially think a little bit more about glossopharyngeal. It is also one, I showed you kind of the neck flexions earlier with hay. I will, when I'm doing my actual neurologic exam in horses, it's actually one of the last things that I do because I don't want them looking for hay the whole time that I'm working with them. But I'll do those neck flexions, but then actually let them take the hay, watch them chew it and swallow it. So that live action, I can kind of be assessing cranial nerve 9 and 10 here, which we're going to talk about in a second. So 10 is vagus. So again, it is going to be laryngeal and pharyngeal function. Big portion of it relative to what we can discern in a cranial nerve exam. Again, will be swallow as well as the slap test. So that's where you're going to put your fingers on the horse's larynx and then slap the contralateral wither, and you should feel that slight abduction. Or more specifically, you could stick a scope in them and actually look at their arytenoids. And so, when looking at the left arytenoid, when I slap the horse's right wither, I should see that left arytenoid abduct, and vice versa. Now, obviously, if the only portion of your neurologic exam that you ever find is that to be abnormal in a specific horse is that they're missing that slap test on the left arytenoid, am I going to diagnose that horse with some horrible neurologic disease? No, I'm going to say it's probably just a roar, but important to try and test the slap test in each horse on both sides as part of a complete neurologic exam. Cranial nerve 11 is spinal accessory, so it is motor and sensory to the cervical apaxial muscles. So really looking for either symmetric or asymmetric muscle loss in the neck. And then cranial nerve 12 is going to be hypoglossal, so it's going to be tongue. So it is motor to the tongue. So we're going to be looking for tongue symmetry and tongue strength. So again, the horse should have the same amount of muscle on each side of that central sulcus of the tongue. You'll notice probably in really all of these videos where people's hands are in horses' mouths, we should be wearing gloves, so do as I say, not as I do. But looking for that tongue symmetry, there's those classic pictures of horses with EPM where one side of the tongue is all shriveled and the other one is normal. We also want to look for tongue strength. So you're going to reach into the horse's mouth through the bar of their mouth so that you don't get bit, grab their tongue and pull it out to each side. And a normal horse, when you pull their tongue out to the side like this, should be able to replace their tongue in less than 2 efforts. If it kind of just hangs out there like a dog, that is going to be abnormal. And here's a video sent to us by a horse owner. You can see actually that this horse is down. Sorry, it's not a great video, but pulling the horse's tongue out. So again, kind of going through the side, pulling the tongue out, let it go. And you can see that that horse retracted the tongue with one effort. Interestingly, that horse did have botulism. And I think classically people always think every horse with botulism will have decreased tongue tone. That certainly is not always the case. So still a good rule out if a horse does have abnormal tongue tone to have botulism high on your list, but don't rule out botulism if the horse appears to still have normal tongue tone. So those are all of the cranial nerves. And so like I said, the one thing that's somewhat nice about thinking them in numerical order is to some extent that's also the same order that they come off of the brainstem. So if you had a horse that as part of your cranial nerve exam, you decide that that horse has, cranial nerve 2 and cranial nerve 12 abnormalities, but all the other cranial nerves are normal, you're going to say that horse has multifocal disease because that's something kind of more rostral in the brainstem and more caudal in the brainstem. Versus if you have a horse that you decide has cranial nerve 4, 5, 6, 7 deficits, then that may still all be attributable to one lesion that's big enough to span that whole area of the brainstem. So that's where it is kind of important to think about exactly which cranial nerve abnormalities they are when we're trying to say, is this focal disease or multifocal disease? So then moving back from the brainstem, we're going to start to get into our spinal cord exam. And so some of this is going to be some reflexes that we're going to do in the stall, and then we'll start to take the horse outside. So we'll look at the cervicofacial reflex, which actually the next video will show you that, but that is one where you are going to kind of poke the horse down the neck and trigger those cervical dermatomes. And when you do that, the horse should flick its ear, blink its eye, and or retract its lip. We're also going to do paniculus. So that is going to be where we feel up the costochondral junctions and the horse's cutaneous trunci should move. And then we're going to do some postural reflexes. So this is where we ask the horse to flex and extend their back. And when they do that, they should be able to keep their stay apparatus locked. I think this is a common misconception, especially horse owners. They'll do this video I'm going to show you here in a second for postural reflexes, and they'll say, well, if the horse, flexes its back, it must have back pain. And that's not true. In fact, I would say for the most part, horses that have really bad back pain won't flex and extend their back in response to manipulation because they're trying so hard to kind of brace that painful area. So a normal horse, again, when we come along their back muscles, they should flex and extend, but they should be able to keep their coordination and balance and keep that stay apparatus locked while they do it. And then we're going to move back to the tail and anal tone and look for things there. So again, I've got 2 videos we'll show you. So this little colt here was a 6-month-old paint colt that you'll see in a couple of videos, but here doing his postural reflexes. So again, they should extend and then flex. And when they do that, they should, again, kind of just move their back like they were doing a little yoga maneuver, but be able to keep their stay apparatus locked. And you can see that he is not able to do that. So I'll show you the video again. So when he flexes there, he kind of just falls off that whole stay apparatus. Spoiler alert, this horse did have Wobbler's disease. So again, we're going to go through this in a slightly slower video and kind of go through all those reflexes. So again, in this horse, we're going to start with that cervicofacial reflex and then work back from there. Now we're actually being good and wearing gloves. So again, as we come along the neck, you should see his ear flick and or his blink and or him retract his lip there. And so he is one that actually consistently, when we got to C5, no longer moved his ear or blinked his eye. I apologize, it's a GoPro video, so it's not the best quality in the world. So now doing paniculus, and for that I just used my thumb and just come up those costochondral junctions. You can see that he did appropriately move cutaneous trunci. And then coming on along thoracolumbar and lumbosacral, again, he should extend and flex and be able to keep his stay apparatus locked when he did it. Now you can see there, he kind of preferentially cocked his leg at the end just to rest. So I'm going to ask him to get his weight back on that leg and stand squarely, and then do it again. And you can see again that he is able to actually maintain that. And then without getting yourself kicked, come back, feel for tail tone, and then look for perineal sensation and tone. So again, as we kind of poke along there, they should just clench their muscles and then do a little bit of anal retraction. So again, always be careful, especially in a young horse. This was a super well-behaved, very lovely gelding, but obviously be careful when you're directly behind the horse to just be poking them in the bum. We don't spend a whole lot of time in, especially adult horses, talking about things like deep pain, withdrawal, patellar, or cranial tibial reflexes, because all of those would require the horse to be recumbent. And if they are recumbent, we usually know that we have significant neurologic disease. I am not a person who does a lot of foot placements when looking for conscious proprioceptive deficits in horses. And I'm not saying it's wrong if you do. And you'll see plenty of very esteemed colleagues that do a lot of foot placements. I think just take them with a grain of salt. So foot placements would be something like this, where we pick up the horse's foot and place it in an abnormal position. So either we cross it over in the front or we make it base wide. The thing to me that can be challenging about foot placements is you'll get some really well-behaved horses that just leave their feet there because they think that's what you want them to do. So don't over-interpret foot placements. They can be helpful, but just don't over-interpret them. To be honest, what I almost prefer to do is, as I start doing my moving exam, I'll just ask the horse to kind of stop mid-stride very abruptly in a weird position, and they should then right their feet to get them under themselves if they know where all of their feet are. So I often just kind of like to watch their own foot placements when they end up in a weird spot versus me selectively trying to place their feet in abnormal positions. So just recognize those differences. So then for the moving exam, I'm going to take them out of the stall, and this is where it's really helpful to honestly have a really good horse handler, and especially if you can have a technician that you routinely do these with that does them the same way every time. Often, obviously, you don't have that luxury, and you may be talking a horse owner through it, or you may be sometimes trying to kind of do it yourself and watch what you're doing as you do it. But just really try and be consistent in terms of, again, leading the horse from both the right and the left to look at different things. I'm going to watch them walk in a straight line, both me standing directly behind them. So when I'm behind them, what I'm watching for is going to be any sort of excessive pelvic motion in any plane. So are they kind of sashaying significantly from side to side or bouncing a lot in their pelvic muscles? From directly behind, I can also watch their stride and see, are they tightrope walking, where they're bringing their crossing midline with their hind feet, so they're almost hitting themselves underneath themselves. Are they crab walking, where their hind feet are on a totally different plane than their front feet? Are they doing anything abnormal in terms of, again, kind of that lateral to medial deviation of their footfall? Then I'm also going to watch them from the side, and I'll watch kind of their hind feet and their front feet almost separate times. So often I do make my horse handler walk a fair amount, but what I'm watching for from the side is going to be stride length and symmetry. And so remember, when you're watching their hind feet, that their hind feet should land where their front feet just left. And so if they're consistently short, that can be abnormal, or if they are overreaching, so if they're actually clipping their front heels or pulling shoes regularly, those things will be abnormal. This is one spot that sometimes I think can be helpful to try and figure out that whole million-dollar question of, is a horse lame or is it neurologic? In general, lamenesses, so musculoskeletal abnormalities, are going to be consistently abnormal. So let's say, again, the horse has a left hind limb lameness. Every stride with that left hind limb may be short, versus a horse that is neurologic often will be asymmetrically abnormal, where one time that left hind stride is too short, the next time it's too long, then it's correct, then it's too long, then it's too short. So if each stride length is totally different, that to me is going to be more consistent with neurologic disease than with lameness. So again, I'm looking for the stride length or any sort of toe dragging in both the forelimbs and the hind limbs as I watch the horse go from the side. So we're going to watch this mare, and there is a little bit of a hill that this mare is going down, so just take that in, but it's also in slow motion, which is a great way to watch horses. But you can see in her front feet how she really flicks her toes out and almost seems surprised when the ground reaches up to meet them. So that is kind of that tin soldier gait, or that hypometric gait. And I think this is sometimes confusing, is the hypo versus hyper, but it is actually hypo because she actually has decreased flexion in her carpi to have that same level of elevation. So that is a hypoflexion in the forelimbs. And we're going to watch this video again, and we'll watch her hind limbs this time, and you'll see that her hind limbs, she has kind of excessive pelvic bobble, so she kind of is a little bit bouncy behind. And then if we watch her hind limb gait, you actually could just see her toe drag there. And each stride length is a little bit different. For the most part, she's almost overreaching behind, but then every so often she's actually short behind. So like that stride was short in her left hind. Previous ones, she had just about clipped her left forelimb. So she had abnormalities in both her hind feet and her forefeet, and she actually was a wobbler. So like I said, she actually was incidentally on a small hill just because that was the only place we had to walk her on that particular property. Generally, I would prefer to watch them on a totally flat piece of ground initially, but then if you do have a significant hill, it can be quite helpful. You don't always have the luxury of a hill, depending upon where you are. So some combination of a hill and or elevating the horse's head. And essentially what both of those things are accomplishing are that you're taking away their ability to see the ground and therefore to use visual compensation for knowing when their feet are going to hit their ground. So again, sometimes it can help to elucidate some of those proprioceptive deficits. So if they seem, again, surprised when their feet hit the ground because they couldn't see the ground coming, that tells you that they also just don't have actual conscious proprioception of where their feet are. A good hill can also be really helpful in picking out lower motor neuron disease as well. So a normal horse, when going down a hill, or again, if you can get their head high enough, it's going to shorten their stride to some extent. It's just like you. If you walk down a steep hill, you often take slightly shorter strides, just kind of keep your center of gravity, underneath yourself. So any normal horse will shorten to some extent. If they take teeny tiny, very severely shortened strides, or just flat out refuse or can't do it at all, whether that's going down a hill or can't walk with their head elevated, that's often going to tell you that they have lower motor neuron disease or significant weakness. Again, a horse going down a hill with upper motor neuron disease or proprioceptive deficits, more of a spinal cord type disease, will again have that long floating stride where they're surprised by the ground. And so we can see that in this video. So this horse going down the hill, if you watch his forelimbs, you'll see that long flowy stride. And if you watch his hind limbs, he's super bouncy behind where he kind of can't catch himself. And so again, this was another horse with cervical neck disease. We'll also watch the horse circle, and so when I'm circling them, I like to start them off in kind of a bigger circle and then start to narrow down their circle. And what they should do, and this is a short video, so I'll show it for you a couple of times, but also tell you what to look for first. So what we should be looking for when we get them into a tight circle is that in their forelimbs, they should essentially cross their outside front limb over their inside front limb without hitting it or clipping it or getting stuck or tripping or anything like that. Their hind feet, they should essentially keep just a little bit of forward momentum in your circle. And I think this is one thing that can be hard to get a good circle. You don't want to make them just pivot. You want a little bit of forward momentum. And what they should do is essentially kind of keep moving that inside hind foot to keep that movement. And that outside hind foot, if they're normal, should stay underneath them. If they do what we call circumduction, that's where their outside hind limb just swings wide. And essentially what that is telling us is that, again, that horse does not proprioceptively know where that outside hind foot is. So gravity and centrifugal force are just taking it outside and wide. So again, normal horse should cross the front limbs over, and then in the hind limbs should do small corrections of that inside hind while keeping the outside hind underneath them. If they don't know where their feet are, that's when you're going to see circumduction and or interference. So they may actually just step on themselves, get themselves kind of all crossed over and not be able to kind of right themselves at all if they don't know where their feet are. If they have lower motor neuron disease, so if they have significant weakness, that's where no matter what you try and do with them, they may kind of just plant and pivot because they're not actually able to kind of generate the strength to keep picking up and moving their feet over themselves. So this video here was a yearling Missouri Foxtrot or gelding, and what you'll mostly be able to see in him is going to be the circumduction of this right outside hind. So again, as he circles, you'll see gravity just takes that foot wide. And recognize, again, when you're doing these circles, a lot of it is your handler, and it varies a lot with horse to horse. So these younger horses that maybe haven't been handled a lot sometimes struggle, and you have to give them a little bit of leeway just because they don't know what you're asking right away. The other thing that is important is going to be, and I apologize I don't have a video of it, is that, this same horse, we also want to take it to the right. And when we ask him to circle to the right, you're going to want your handler on his right side. Obviously, we've all been trained to lead horses from the left, but again, because we're trying to really do mirror image exams to figure out right versus left, when I ask him to circle to the right, I'm going to ask my handler to lead him from the right. Especially these young horses sometimes kind of struggle with that initially because often they've just never been handled that way. So again, often I may take a little bit longer going to the right to let them get used to kind of having a person there and kind of what we're asking of them. So again, just kind of always take those things into it. Call this video, how to try and kill your resident mate. So we had already done him at rest, so now walking, you will see Dr. Steeler-Stewart pulling him, and she can just about pull him over on her resident mate, Dr. Hustel, except this is not how you should kill your resident mates, but he was markedly weak and very easy to deviate. We're also going to ask the horse to back up. And remember that the back should be like the trot in terms of being diagonal, so they should move diagonal limbs together. We will see this little mare struggles with that. And so again, it's another slow-mo video for you. So when we ask her to back, she kind of moves each limb totally independent of each other. And if anything, kind of almost tries to pace backwards, which is abnormal. Again, they should move diagonal limbs together. And then she does what is very classic, is she kind of gets to a point where she's just stuck. She kind of doesn't really know which leg to move next and kind of almost gets in that prayer position and kind of gets stuck there. So that would be abnormal. And she also was a wobbler. And I will find, especially a lot of wobblers, even though some of the more subtle wobblers, backing is going to be one of the hardest things for them. Other things that are helpful to do are if you have a curb or ground poles, walking the horse, especially serpentining the horse up and down a curb or over ground poles can be quite helpful. The step up onto a curb helps a little bit, with strength. Can they actually kind of pick their feet up high enough to get up a curb? And then when they come down the curb, that can help us with upper motor neuron disease or proprioception. Again, if they seem surprised when all of a sudden the ground is 4 inches different. So curbs can be really, really helpful. Again, ground poles, do they have trouble picking their feet up or knowing kind of where their feet are relative to a ground pole? Hopping, I do like to hop horses if I'm trying to figure out forelimb abnormalities, especially some of the more subtle forelimb abnormalities. So you would pick up one front leg and ask the horse to essentially bounce on the other front leg away from you in a circle. So again, if they have appropriate strength, they're going to be able to generate that bounce. And if they know where their foot is, they'll then be able to replace that foot and catch themselves. So obviously don't kill yourself trying to do this, but it can be helpful. And sadly, I can't find a good video of it. Someday I'll have one. And then blindfolding horses can also be helpful to look for vestibular disease. The biggest thing about blindfolding is do it in a safe place. So do not do it on pavement. Don't even do it in a horse's stall. If you're going to blindfold a horse, try and do it in a nice sandy arena or a nice grassy field, somewhere that they have good footing and that if they do fall down, they're not going to hurt themselves falling and have a better chance of being able to get back up, okay? You also want to blindfold them with something easily removable. So don't knot a blindfold into their halter. I like to just do kind of this towel tucked between their halters so that if they start to panic, you can easily kind of whip it off and give them their vision back to compensate. And so you'll see in this video, I don't know why it starts off tilted, but it writes itself. So this was one of our THO mares from some of the earlier pictures. You can see with the blindfold on, as soon as we kind of ask her to start moving, she starts to fall dramatically to the left. But again, the beauty of that blindfold is we could easily take it off. And again, you could see once she could see again, she could right her balance. So again, helpful to look for some vestibular disease. So again, in terms of our localization, big question, do we have one or more lesion? So can we say that there's forebrain disease, brainstem disease, and spinal cord disease, and where within those will help us to determine our list of potential differentials, and then also right versus left. So several of the diseases that we see in horses may be more or less likely to be symmetrical or asymmetrical. So we always think of EPM, for instance, as classically having asymmetric issues. We may have some left brainstem disease and some right spinal cord disease. So looking for those abnormalities, both front to back of the horse, as well as left versus right on. And again, we can get reasonably specific with our localization. So if we have behavior abnormalities and or seizures, we're thinking forebrain. If we have a change in mentation or any sort of cranial nerve abnormalities, we start getting into brainstem. And like I mentioned earlier, depending on what conglomeration of cranial nerve abnormalities, we can often say even within the brainstem, is there one or more than one lesion? And then as we start to get into spinal cord, we really can start to localize more and more, which section of the spinal cord are we looking at? And, I think honestly, our small animal colleagues have historically been probably a little bit more specific in this to some extent because they have always had better access to imaging modalities that could help them. Unfortunately, more and more, even in our horses, we are with, various standing CTs and just with DR being so much better than old plain films used to be, we can actually diagnose, abnormalities in many more portions of the horse's spinal cord now. So it really is helpful to really try and focus into a specific area of spinal cord if we're really trying to come up with a diagnosis. So if they have proprioceptive or upper motor neuron deficits in all 4 feet, then they're going to be C1 to C6. If they have essentially weakness in their forelimbs, but then upper motor neuron in their hind, then we can say that we're really, our lesion is at the brachial plexus, so between C6 and T2. If they have just weakness in the forelimbs with normal hind limbs, then we're often in the gray column of that brachial plexus or moving more into nerve roots and peripheral nerves. If the front feet are totally normal, but the hind limbs have upper motor neuron deficits, then we're in T3 to L3. If they have just lower motor neuron in the hind limbs, again, then we're in the lumbosacral intumescence, so L4 to S2, and we're into peripheral nerves. If they have lower motor neuron, so if they have weakness in all 4 limbs, then it's looking at more diffuse musculoskeletal. And then if they have just lack of tail tone, anal tone, urinary fecal incontinence, then we may be back into that sacrocaudal spinal cord or again, those peripheral nerves. So again, we can get more and more specific with that localization. If you go to the don'tstall.com website, there is on that particular website a bunch of neuro exam sheets that you all are welcome to access. So you can print them off and use them for your when you're actually doing physical exams on horses, or again, if it just helps you to conceptualize kind of everything we just talked through. There's a couple of different forms of those exam sheets on there, including some where I do go through and actually kind of define some of the terms. So again, if you look at it and you're like, hyporeflexia, what does that mean? There are some notes on there to help differentiate those. So hopefully those help you all. Hopefully this talk helped you all feel a little bit more confident in how to do a good equine neuro exam and how to interpret it. And I think it is important to remember that if you lose your head, you will have a seizure and then you will die. So even robotic horses still need a forebrain. And with that, I hope you all have a good day. Take care.